You're listening to the Hoofcare Companion, the podcast dedicated to the science, art and practicalities of keeping horses sound from the ground up. I'm your host, Marc Jerram, and each episode will take a deep dive into the world of hoof anatomy, pathology, care and rehabilitation. Whether you're a farrier, veterinarian, therapist or simply passionate about horse health, this is your space to learn, question and grow. We'll explore the latest research, time-tested methods and real-world case studies to help you better understand the structures beneath the hoof capsule and how to support them when things go wrong. Because good hoof care isn't just about trimming and shoeing, it's about understanding the whole horse. So let's get stuck into today's topic. Episode 2. The role of nerve blocks in identifying equine lameness.
Introduction.
The diagnostic evaluation of lameness in horses relies heavily on accurately locating the source of pain. Among the most effective tools in this process are regional or perineural nerve blocks, which allow the clinician to anaesthetise specific regions of the limb and assess the subsequent changes in gait. Administered in a systematic distal to proximal order, these blocks provide critical insights into the anatomical origin of lameness and help differentiate between potential pathologies. Over the past decade, advances in technique, pharmacology and imaging have refined the effectiveness and accuracy of nerve blocks, cementing their role in equine veterinary diagnostics. Nerve blocks work by depositing a local anaesthetic near a nerve or synovial structure, temporarily halting nociceptive transmission from that region. Following administration, the horse is reassessed in motion and any reduction or elimination of lameness helps confirm the location of pain. This approach provides a functional test of pain response and is most effective when performed in a stepwise fashion from distal to proximal regions. Brown et al. 2025. This strategy minimises the chance of anaesthetic diffusion from a proximal block affecting a distal site, which could confound interpretation. The choice of anaesthetic is critical for successful diagnostic blocking. Mepivacaine is commonly used because it provides a moderate duration of action and minimal tissue irritation. Lidocaine, though quicker in onset, has a shorter duration and is often less practical for prolonged evaluations. Bupivacaine is reserved for longer-lasting effects, such as post-operative analgesia, due to its slower onset and potential for cardiovascular toxicity at higher doses. Using smaller volumes, such as 0.75 millilitres instead of the conventional 1.5 to 2 millilitres per nerve, has been shown to reduce unintended anaesthetic spread and increase diagnostic precision. Cole et al. 2024. Accurate needle placement and appropriate waiting times are also essential. Typically, gait reassessment is performed 10 to 15 minutes after distal blocks and up to 30 minutes after proximal or intra-articular injections. Clayton 2010.
Palmar digital nerve block.
The palmar or plantar digital nerve block, PDNB, is often the first performed when investigating distal limb lameness. This block desensitizes the palmar digital nerves at the level of the pastern, targeting the heel, sole, distal interphalangeal joint, and navicular apparatus. A positive response to this block suggests that pain is localized within the hoof capsule or navicular region. Research has confirmed that using lower anesthetic volumes, 0.75 milliliters, yields diagnostic efficacy equal to higher doses, minimizing the risk of proximal diffusion. Furthermore, experimental blocks using plant-derived agents such as pitcher plant extract have demonstrated comparable results to mepivacaine, offering potential natural alternatives. Johnson et al. 2023. In a 2023 pharmacokinetic study, Gneich et al. Explored the behaviour of lidocaine combined with epinephrine in palmar digital nerve blocks. They found that the terminal half-life of lidocaine was significantly extended, with drug metabolites remaining detectable in serum and urine for up to 48 hours. These findings have practical implications, particularly in performance horses where regulatory withdrawal periods must be observed. Similarly, Alvarez et al. 2018, demonstrated that the addition of epinephrine not only prolonged the block's duration, but also enhanced its effectiveness without introducing systemic complications.
Abaxial sesamoid nerve block.
The abaxial sesamoid nerve block, or low palmar digital block, desensitizes the entire foot, including the toe, coffin joint, and navicular apparatus. It is commonly used when a PDNB yields incomplete results or when further refinement of pain localization is needed. This block is particularly helpful in identifying pathologies such as coffin joint osteoarthritis, deep digital flexor tendon injuries at their insertion, or solar margin fractures of the distal phalanx. Brown et al. 2025 evaluated different anaesthetic volumes in this block and concluded that low volume 0.5 millilitres injections were equally effective as larger volumes 2.5 millilitres, again highlighting the diagnostic benefits of minimal anaesthetic spread.
Low 4-point block.
When pain persists despite distal blocks, the low 4-point block is used to anaesthetise the palmar and palmar metacarpal nerves just proximal to the fetlock joint. This block desensitises the fetlock joint, digital flexor tendons, suspensory ligament branches, and sesamoidean ligaments. It is particularly useful in detecting injuries like proximal sesamoiditis, suspensory branch desmitis, and fetlock arthritis.
High 4-point block.
The high 4-point block, which targets the same nerves at a more proximal site, can help identify lesions in the proximal suspensory ligament, distal, superficial and deep digital flexor tendons, or digital sheath adhesions. These blocks require larger anaesthetic volumes and precise technique to avoid diffusion to adjacent areas. Recent clinical practice increasingly includes ultrasonographic guidance to improve localization. Smith et al. 2020.
Case applications demonstrating diagnostic power.
Several illustrative clinical scenarios from recent literature demonstrate how nerve blocks are applied in real-world equine practice.
Case 1. Navicular versus coffin joint pain.
A 7-year-old warm blood gelding presented with subtle forelimb lameness, graded 2 out of 5. Palmar digital nerve blocks eliminated lameness only partially. Abaxial sesamoid and coffin joint intra-articular blocks resulted in complete resolution. Radiographs confirmed mild coffin joint osteoarthritis with synovial effusion. Low volume abaxial block had accurately localized distal interphalangeal joint pain. Brown et al. 2025.
Case 2. Suspensory branch desmitis.
A performance mare exhibited worsening fetlock hyperextension and moderate hind limb lameness. Proximal digital blocks failed. Low metatarsal, 4-point, block resolved, lameness. Ultrasonography revealed focal lesions in the lateral suspensory branch. Low volume perineural block was sufficient for localization and guided subsequent focused treatment.
Case 3. Deep digital flexor tendon sheath irritation.
A thoroughbred with mild forelimb lameness on the turn was examined. PDNB resolved the lameness completely. Abaxial block produced no further change. However, intra-sheath injection into the digital flexor tendon sheath, without additional improvement, differentiated lameness originating from navicular compared to tendon sheath pathology. Beyond these common blocks, intra-articular and intrasynovial injections allow for direct anaesthetization of joints or tendon sheaths. These are often employed after regional blocks suggest a synovial source of pain or when advanced imaging indicates intra-articular pathology. Commonly targeted sites include the coffin joint, fetlock joint, carpal joints, and navicular bursa. While highly specific, these blocks are also subject to anaesthetic diffusion. In particular, injecting large volumes into the coffin joint can result in inadvertent navicular bursa desensitization due to anatomic communication. Brown et al. 2025. Consequently, careful volume control and knowledge of joint anatomy are essential to prevent misinterpretation. False negatives and false positives are inherent risks in diagnostic analgesia. Inadequate technique, insufficient anaesthetic spread, early gait assessment before onset, or atypical innervation patterns may result in false negatives. Conversely, excessive volume, poor technique, or needle misplacement can lead to spread into adjacent regions, producing false positives. Clayton, 2010. To mitigate these risks, low-volume, high-precision blocks are increasingly favoured. Additional diagnostic tools such as objective motion analysis systems have also improved interpretation and reproducibility of results.
Quality control and standardisation in practice.
Given the reliance on nerve blocks in equine sports, regulatory bodies have prioritised standardised protocols and withdrawal time monitoring. The FEI and racing authorities now mandate record keeping of block type, anaesthetic volume, agent, and date night time administered. Pharmacokinetic data from Nike et al. 2023 underpins withdrawal guidelines, requiring at least 48 hours post-epinephrine containing block before racing. In teaching institutions, structured lameness labs have been established to improve competency. Students are taught perineural anatomy, aseptic technique and dose control. A 2022 paper by Wilson et al. Surveying veterinary students across Europe found that competence scores increased from 45% to 82% after targeted training, underscoring the importance of didactic preparation. Systemic complications from nerve blocks are rare, but include hematoma formation, cellulitis, and inadvertent intravenous injection. The use of sterile technique, appropriate restraint, and careful aspiration before injection can reduce the incidence of such complications. Infected or inflamed tissues should be avoided, as blocks in these areas may exacerbate local pathology. More recent innovations have included the use of dexmedetomidine, an alpha-2 adrenergic agonist, in combination with mepivacaine. Smith et al. 2020 found that this combination extended the duration of palmar digital nerve blocks in healthy mares without causing excessive sedation, offering potential for prolonged diagnostic or therapeutic applications. Meanwhile, studies like that of Johnson et al. 2023 have explored natural agents such as pitcher plant extract, demonstrating that even botanical compounds can yield comparable analgesic effects to standard agents. The pharmacokinetic properties of various agents are increasingly guiding clinical protocols. Alvarez et al. 2018 and Neich et al. 2023 provided detailed pharmacodynamic profiles that help inform safe withdrawal periods in competition horses. This information is essential not only for treatment planning but also for adherence to racing and sport regulations.
Integration with advanced imaging and motion analysis.
As diagnostic tools advance, nerve blocks are increasingly performed in tandem with modern modalities. High-resolution ultrasonography is now commonly used to visualize tendon and soft tissue structures before and after block placement, enhancing precision. Portable imaging modalities allow dynamic palpation during needle insertion, reducing misplacement. Objective gait analysis, using systems like SLAPE or lameness locator, enables quantification of vertical head and pelvic movement before and after block. Cole et al. 2024 found that integrating gait metrics increased block interpretation accuracy by 22%, particularly in equivocal 1/5 lameness cases. Furthermore, motion capture identified transient asymmetries not visible to the naked eye, improving diagnostic sensitivity by 14%.
Economic and ethical considerations.
Accurate diagnosis via nerve blocks can reduce unnecessary advanced imaging or treatments, thereby lowering costs and improving welfare. A retrospective analysis by Thompson et al. 2023 reviewed 125 lameness cases at a referral hospital and concluded that earlier application of distal blocks altered 48% of initial diagnostic plans, avoiding 5 MRI scans and 12 CTs, and reducing overall cost by approximately £2,800 per case. Ethically, reducing anaesthesia and general procedures enhances horse welfare. Minimally invasive perineural methods reduce sedation risk and recovery complications, aligning with modern veterinary ethics, emphasising non-painful diagnostics and least harm principles. The future of diagnostic nerve blocks is likely to involve increased integration of imaging, pharmacologic precision, and even nerve-targeted therapies. Innovations such as ultrasound-guided radiofrequency ablation of the palmar digital nerves have shown promise as both diagnostic and therapeutic tools in horses with chronic distal limb pain, Johnson et al., 2023. These procedures may become valuable in managing refractory lameness cases where standard blocks are insufficient or non-diagnostic.
Conclusion.
Nerve blocks remain an essential component of lameness investigation in horses. When applied systematically and with proper technique, they provide precise information about the location of musculoskeletal pain and enable targeted diagnostic imaging and therapy. Advances in pharmacology, imaging and block technique over the past decade have significantly enhanced the accuracy, safety and utility of this diagnostic method. As research continues to refine our understanding of nerve block dynamics, equine practitioners are better equipped than ever to localise pain and implement effective treatment strategies that promote recovery and athletic longevity. Thank you for listening to the Hoofcare Companion. Please follow, rate and share this podcast on your social media to help the Hoofcare Companion grow and reach all of those who care for our equine friends all around the world. Visit the links in the show notes to obtain your copy of my books or to interact on my social media channels. Until next time, thank you for listening, because a healthy hoof is a happy horse.